Good afternoon, everyone. I would like to take a moment to introduce you to the VPS Research Spotlight. Today, we will have Dr. Kim Aldy do the presentation. Dr. Aldy holds a master's in biomedical science as well as business administration. She received her doctorate of osteopathic medicine at the University of North Texas Health Science in Fort Worth. She is boarded in emergency medicine and medical toxicology, and has authored or co-authored more than 48 peer-reviewed publications. She currently serves as the program director of Toxicology Investigators Consortium and as a medical toxicologist and ER physician at Baylor University Medical Center in Dallas. Today, she'll be discussing a recent JAMA publication in which she, Dr. Wax, and colleagues utilized the VPS registry. The article is entitled Medical Toxicology Consultations and Mortality Among Patients with Poisonings in the PICU. Dr. Aldy, you want to have your presentation?
Thank you so much, Dr. Rice. I'm going to share. Well, welcome everyone. Thank you for that wonderful introduction. So as Dr. Rice mentioned, my name is Kim Aldy, and I'm the program director of the Toxicology Investigators Consortium, which is a research branch of the American College of Medical Toxicology. None of the authors have any conflicts of interest to disclose. So as a very quick introduction, the American College of Medical Toxicology is a national membership society that serves medical toxicology physicians. And medical toxicology itself is a field of medicine that's dedicated to the evaluation and treatment of poison patients. And typically, medical toxicology physicians provide consultations, either in the emergency department, ICU, but they also have outpatient clinics, and many are part of poison centers around the country. And the mission statement that we have at ACMT is advancing the toxicologic care of patients and populations, which brings us to this paper that recently came out in JAMA Network Open earlier this year, looking at medical toxicology consultations and mortality in patients that have poisonings in the PICU. So the objective of the study was to examine the impact of medical toxicology consultations and outcomes in PICU patients that had poisoning diagnoses. And limited research to date has been conducted on the impact of these consultations, particularly among PICU patients, which are quite a vast, very difference in these patients that are in the PICU, but also as toxicologists, these are the patients that we quite frequently get consulted on. This analysis of the VPS database was from January 1st, 2019 to June 30th, 2023. And in order to figure out which patients had poisonings, we used the STAR diagnoses codes for poisoning, so intentional and unintentional overdoses that are related to their visit, as well as adverse events related to medication errors and envenomations. The primary outcome here is to look at the PICU mortality and hospital mortality. In addition to that, we had secondary outcomes looking at the length of stay, and these were measured in days. In addition, we looked at the primary predictor, which was the medical toxicology consultation. So in the VPS database, this is documented as a consultation service. And so if it was checked off, then it would be yes. And if it was not there for these patients with poisonings, it would be no. We also looked at demographic variables, covariates, including PRISM-3 with PRISM-3 and PIM-3, and looked at trauma status to ensure that this was not changing the mortality in these patients. And the data analysis included the vast array here, which I'm just going to briefly go over. So we looked at basic differences in those with medical toxicology consultations and those without. And we looked at their demographics, primarily here, which are age and sex, and race and ethnicity. Then we looked at whether the medical toxicology consultation was linked to better outcomes or not. And we accounted for possible hospital differences, which could contribute. For instance, toxicologists are typically at tertiary centers in bigger cities, and it could be that some hospitals have more resources than others. And so we accounted for that as well. And then we did a sensitivity analysis where we looked at hospitals, only the hospitals with the toxicologist available, and made sure that the findings weren't skewed by those hospitals without access to toxicologists. And then we evaluated those patients less than 2 to ensure that these results weren't skewed at these younger ages that may have um, less severe poisonings, and sometimes more severe poisonings, depending on where you are. Then we looked more closely at the different categories of drugs that toxicologists see, and that included analgesics, antidepressants, cardiovascular agents, and opioids. So our results here are laid out for our demographic variables. So 52,836 PICU patients were identified with a poisoning diagnosis between 2019 and 2023. This is only 10% of all of the patients that were entered into the to the VPS system during that time period. 56% of these were female, so the larger majority were female. And 57% were in adolescents or young adults. So these are patients between 12 and less than 21, so 20. 52% of these patients were white, 15% were Black, and 15% were Hispanic. So, there's quite a varied difference here, although white was the majority. And 5.4% of these patients had received a medical toxicology consultation, which is what we expected, knowing that this is a national database and medical toxicologists are not at every hospital. So looking at our bivariate analysis here, you can see in the middle we have no medical toxicology consultations on the left. And then on the right, we had those with medical toxicology consultations. And basically what we found was that PICU mortality and hospital mortality was lower in those patients with a medical toxicology consultation. And in addition, further analysis showed that, showed that there was no statistically significant difference between the PIM-3 scores and PRISM-3 scores for those with medical toxicology consultations and those without. And so these are severity scores for mortality, and there was no difference. So that helps us see that possibly medical toxicology consultations are the reason for this lower mortality. And here we have the length of stay as well. So the medical length of stay is the length of stay that does not include any time for transfers. Some of these patients that have intentional overdoses may need transfer to a psychiatric facility, and in those cases, it may delay their transfer. So this is what this medical includes. The physical would be the ICU timing, and then the hospital is their total length of stay in the hospital from beginning to end. Looking at our multi-level model results for medical toxicology consultations and mortality, we can see those that received a medical toxicology consultation had reduced odds of PICU mortality as well as hospital mortality. And looking at this further to account for other things that could contribute to their mortality, one of the things we looked at, was the trauma. So trauma differences, you can see here, there's really not much difference in the trauma, meaning that trauma likely did not contribute to this mortality difference. We also looked at analgesic, antidepressant, and cardiovascular and opioid poisonings and accounted for that to ensure that this didn't skew the results. Oh, sorry. I think that was a duplicate, sorry. So this study basically showed that medical toxicology consultations were associated with reduced odds of mortality and reduced length of stay. And our sensitivity analysis for younger ages didn't show any differences in those with and without medical toxicology access. Now, even though this study did have a large amount of patients in it, luckily VPS did have quite an amount of patients in their database during the time period. This analysis does have some limitations. So it did not include procedures or pharmacological interventions. So those that may have received antidotal therapy and those that did not were not included in this study. And patients with unknown race and ethnicity were excluded from our multivariable models as they could not be accounted for. In addition, Those patients that got a medical toxicology consultation were signified as that by the person that entered the data checking off that a medical toxicology consultation was performed. Now, at some hospitals, the medical toxicologist also may have another field. So they may do emergency medicine, for instance, and they may be classified as an emergency physician in the EMR. And so in those cases, it could be possible that some of these cases that are non-medical toxicology designated cases actually did receive a medical toxicology consultation. It just was not identified during data entry. So that could be an issue, although we think that that's unlikely to be much of an issue. And finally, the timing of the medical toxicology consultation was not captured in the data set. Sometimes the toxicologist will get consulted very early if it's identified as a poisoning, but sometimes these cases may be identified late after more information is gathered from the parent or anybody else that was at the scene. And in those cases, the toxicologist may come in later after antidotes were already given. So, in conclusion, the study really highlights the potential life-saving impact of medical toxicology consultations in PICU patients with poisoning diagnoses. And we do feel that future studies will need to examine the mechanisms underlying reduced mortality and shorter length of stay. And also, the timing of the medical toxicology consultation should be evaluated to help us gather how much this is contributing and at what time period is most beneficial. And I think that's all I have.
Thank you, Dr. Aldy.
Thank you.
Let's open it up and we'll see if we get some questions here. Here's one question. Dr. Mudit Mathur is asking, how many of the patients without an in-person medical toxicology consultation had consultation with a poison control center?
That's a really good question. That's another limitation here. So we feel that likely these patients that were checked off as medical toxicology consultations were not due to poison control centers. Those are not considered official consultations. They're also not typically a consultation note because the person that's doing the poison center consultation does not typically have access to the EMR to put in a note. So this is what we call an informal consultation. Now, in that case, we do believe that those likely weren't checked off in VPS. However, some of the patients that were not deemed to have medical toxicology consultations, there may have been a poison center that was called, and the case may have been discussed with them. But in that case, you would think that it would be a higher amount. It would be similar to those with a medical toxicology consultation, which isn't typically true. A lot of times, when a medical toxicologist is actually at the bedside, they're able to give much more comprehensive care and talk to the team more readily. Whereas when there's a phone call to the poison center, it's typically a quick recommendation, but not specific to the patient always. Sometimes it's just, hey, everybody with an acetaminophen should get NAC, or that level sounds like it could be fine, but they didn't see the patient, so they don't know if the patient really would benefit. So I do think that's minimized in this study, but that's a very good question.
Thank you. Looks like there is another question here from Dr. Soto Campos. And he's asking, did you observe differences in outcomes between the rural versus the non-rural PICUs? And if so, were you able to control for that in your analysis?
So we, just like other VPS studies, I believe, we didn't get the exact hospitals. We got a code that told us that some of these hospitals, which cases were from the same hospital, so we could account for that. But we don't know exactly where these hospitals were, so we were unable to identify those that were rural and not rural, although that would be a very good future question because those that are not rural may not have other specialists like cardiologists or neurologists or even ability to get dialysis because they may not have renal specialists. So we did not look at that, but that would be a great future study.
I think one of the reasons Dr. Soto Campos is asking that is we have had other researchers look at the rural versus non-rural, and they were able to come close to getting some separation utilizing the zip code information.
Oh, that would be great. Yeah.
So, of course, some of it had to be lumped together because of HIPAA requirements, but I think there's a way to get to it with a fair amount of accuracy if that was a secondary analysis or a question that comes up again.
That is a great future study. Definitely we'll have to look into that.
Let's see, a couple more questions are showing up here.
Oh,
Lori Keith is asking, did you only include units with medical services providing care to the patient, checked on their data collection profile? This would remove units that don't collect consultations.
that's a good question. I'm not sure if that contributes to the way that the data entering, or the person that entered the data um, entered the data. So I'm not exactly sure if it included uh, patients where they didn't collect consultations. I think if there would be a consultation, they would enter it. Yeah.
Yes, but I think unless they checked off on their data collection profile, I don't think we generally provide that information from the VPS in the data request. I think Dr. Soto Campos might, or Nancy might be able to answer that while we're on the call. Gerardo?
Oh, these RUCA codes, I think is what I see.
Yeah, Gerardo, are you able to talk?
I don't know if he's on the, oh, there he is.
He just unmuted. Gerardo?
Oh,
Oh, he muted again. Having a little trouble there. Let's, I think,
Yeah, can you hear me?
yeah,
yeah.
we got you now, Gerardo.
Oh, I'm sorry. Can you repeat the question, Dr. Rice?
Yeah, look, the question came up is whether or not whether the data pool included units that didn't have the medical services checked off on their DCP. In other words, would we have picked up some that didn't have it checked off? In other words, they didn't commit to collecting all medical services on their profile.
Mm.
And what I was under the impression that the data that we would have provided back to Dr. Aldy and the colleagues was that we would only provide the data regarding that if it was checked off in the DCP,
Oh,
because
yeah,
otherwise we could get
that's
biased information.
our MO. Only data that is checked on the DCP is provided for research projects.
And
So,
for those that are on the call that aren't familiar with it, the DCP, it's an optional field. If a unit checks that off, that means that they're committed to collecting that data or answering that on every patient that goes into their VPS, so that they'll get flagged before they close that case out. They can't close it without answering it. That eliminates the possibility that there may be some selection bias along the way. So that's why we do it that way. So to answer that question, Lori, essentially all the units in there that collected it were the ones that committed to collecting it on every patient. And the random units that didn't, who just might have had some bias, we didn't include in the data that was analyzed by Dr. Aldy and her associates.
yeah,
There's a comment from Dr. Mathur. He said, in my experience, the Poison Control Center calls and follows the patient regularly, at least on a daily basis. It's possible that those patients without any sort of consultation had even worse outcomes
yeah,
and affected the non-medical tox group's outcomes. So,
that's a very good point. Yeah, they do. I mean, they do call because they want to, put that into their own record, but it's not always that they provide any more help. Sometimes it's just to complete that record for them.
comment from Dr. Bauer. Question, great work. Medical toxicology makes sense in peds centers. If I read your data correctly, it seems like the number needed to treat to save a life is about 50?
As soon as I read that, I was like, oh, I'd have to do the math. And full disclosure, we have a epidemiologist and statistician that worked with us on this study, and she would be able to tell you absolutely. But definitely, we know that it is decreasing mortality in that, but I don't know if it's exactly about 50.
Okay, and then one from Jamie in Colorado. I believe consultations are optional, so hospitals not collecting them should be excluded in this type of study like this. So I think we've already answered that by using the DCP, Jamie.
Yeah.
Let's see. Is that all the questions? How are we doing with that?
B.
Fine, we'll wait. Kim, what kind of problems did you and the team encounter while you were kind of trying to design this study? I know that it was kind of struggling there for a while to figure out which data to use.
Well, so one of the big issues that we came into was looking at the star codes. So, for instance, I believe it was for chemotherapy. We all sat down and were like, okay, those with chemotherapy, they're also lumped into vitamins. And so, in that way, that type of exposure, I mean, chemotherapy exposure is vastly different than a vitamin exposure, like a melatonin exposure or something. Like the mortality there can be so different that it's difficult to interpret together. And so for us, I think the lumping of some of the poisonings were a little difficult to tease out as to, do these meld together? Does it make sense? Which is one of the reasons why we pulled out these specific, more common and also dangerous exposures like opioids and analgesics and antidepressants, which we see very, very commonly. Um, and so that was one thing, but also, in Toxic, our research consortium, we have our own database that has over 100,000 cases, but that is nothing compared to, this database. And when we got the sheer volume of cases, it can be difficult to sort through when you're not fully, knowledgeable about how the database works. And just like this question that someone just asked, I don't know how the data is processed before we get it exactly and what cases are included and not included. And so that was some work to try to work through and try to figure out.
Yes. Well, I think just the sheer volume, I think the use of the star codes developed over time primarily just because of the sheer volume of ICD codes.
Yeah.
So it makes it easier to pull data, but sometimes it makes it harder to tease it out unless you start looking for the ICD-10s inside of that, which,
Yeah.
with 70
That's
some
not
thousand.
always exactly. And when you look at ICD-10s for tox patients, it's not always like they're going to say opioid overdose. Sometimes they'll just say, altered mental status. And that doesn't really get at the exact drug, especially for vitamins. I mean, I don't think anybody would say vitamin exposure. They would just tell you what the patient has, maybe vomiting, or something like that. So it does get harder to tease out, even with ICD codes.
Yeah. I see Dr. Bauer has another question. He's asking, what kind of feedback have you received from academic communities where you have presented your work? I suspect toxicologists have been fairly encouraged and enthusiastic about the results. So, but he's asking, have you received any negative reactions?
Not to my face, but I mean, as toxicologists, we are pretty excited by these results, but I haven't received any negative reactions. That said, I haven't presented this data to anyone that's necessarily a group of non-toxicologists, so I think we've just been in good company. But yeah, I mean, that's a very good question. And I don't think that this diminishes the fact that other specialists are needed. I just think it highlights the fact that having somebody that's very specialized and has seen many of these patients and has that experience with the types of treatments and, how early do you need to give that treatment to ensure the patient does well. That type of stuff is definitely needed for any team to make it multidisciplinary, really. So I hope that no one's given us any bad reactions behind our back, but we haven't heard of any yet.
See if there's any other questions. I had another question is, I know a little bit of the background of putting this all together. So what's the kind of plan for the future here? Anything brewing on your end and the toxicology team?
We have discussed looking further at specific subgroups that we know have higher rates of mortality, like the opioid subgroup, and the cardiovascular for sure with beta blockers and calcium channel blockers, which are what we call one pill can kill lists of drugs. So we have talked about looking at those in detail and seeing if there's any differences. You know, I'm going to guess that likely when you get into these very high mortality cases like cardiovascular drugs, that we may see that the mortality is higher, and we can really see, you know, what the contribution of medical toxicologists are there.
One thing I was thinking about is on my end at the VPS is that the VPS and Children's Hospital Association with their FIS database is worked on developing a linkage so that we can link the two registries databases together. And as you probably are aware, the FIS database is primarily administrative, but it has cost charge data as well as medications, whereas the VPS has more of the clinical pieces. It's about ready to be opened up for investigators to submit proposals, but there's in the process, we currently have there's 31 hospitals that are members of both of those organizations. We have been able to, using probabilistic methods, we've got over 300,000 patients between 2017 and 2023 that would be available for query or research. And so you might have some interest with your team of potentially looking at one. You could probably get more specific information about medications that were actually used, not necessarily what, but they also probably would also have availability of some ICD-10 codes as well as cost or charge data in addition to the clinical outcome information.
That's
So
a
it
good point.
might be a spin-off of that in that. So
Yeah, we will
just some thoughts.
definitely look into that as soon as it opens. That sounds like an exciting way to look at the study-sensitive mortality, looking at cost changes, which, you know, when it comes to medical toxicology, that is one of the arguments that we make. You know, the length of stay is shorter because there's somebody there that's comfortable with these patients and understands when they're ready to go, and doesn't hold back in discharging if they are able. So that would be really, really interesting. We'd be
Right.
definitely interested in that.
And the other advantage, the FIS database also includes, it's the whole hospital stay. So it's the entire inpatient stay.
Yeah.
I don't see any other questions, Dr. Aldy, and we're kind of at our time limit. But I want to thank you very much. It was a very nice presentation, and
Thank you.
hopefully we'll hear more from you and your team in the future.
For sure. Thank you so much
All
for
right.
having me.
Yep. Thank you, everyone.
Bye.